So if the polypectomy is not easy and you're struggling, what sort of things can you do? And this is a nice picture of a very difficult situation. So and I said this at a certain point in Tomaz's case, I said it to you, I'm thinking as a trainer of the things you could do to improve this situation. Right? One of them is manage the fluid better. We had no issue in that case. If the patient's not fully sedated, then sort the sedation out. And so there was a lot of scope holding and maintaining the position at 5 to 6 o'clock, using retroflexion because it is inherently more stable if you're in retroflexion. In the stomach and for ESD, this is a critical technique. In the colon, why are you having trouble with the snare placement? Why is your injection not working? This is what John was talking about yesterday. Create a step for the snare placement, as in resect subnormal mucosa first. Do hybrid, as in use the tip of the snare as or a knife. And so it can be that gravity might help you in that situation. And the sigmoid. So this is where basic technique comes in handy when you're doing therapeutics. Like, the left side of the colon is best in the right or underwater on the left. Perforation is, of course, something which will happen to you at a certain point. You see a video on the left here where the endoscopist has got a snare stuck on a fold, very much a situation like that polyp that we just did. If you had done hot snare polypectomy, maybe this would have happened. And then post-EMR bleeding. So you see in the video, or you will see in the video, some bleeding from a defect that looked like that, and then there's severe bleeding after EMR. What do you need to do about that? You need to resuscitate, sort out any coagulopathy and monitor, but you also need to decide whether you will do something. And to decide whether you will do something and a follow-up plan for surveillance. And of course, think about genetics in big polyp in a young person or multiple polyps. And of course, if you incomplete procedure, what are the next steps for the patient? And they need to know that. Don't travel for 14 days to a remote area. There's a lot of debate about whether that should be 7 or 14.
Belgium, there's not much.
So not directly after, but during surveillance colonoscopy, how should you do surveillance? Well, of course, exactly what I've just said. How are you going to find a scar after bowel preparation is poor? Talk about how complete the colonoscopy was. Look for the scar, find it, document where it is, image it, photo document it. There are many, but they're not EMR based. And then finally, once you finish training, how many procedures should you do? And the task force came up with a number of 30 independently over a minimum period of 60 months, and then use SMSA score to determine where you're at. So we get that going, and then I think we can summarize this by saying that piecemeal EMR is pretty safe and effective. Rates of recurrence with thermal ablation are negligible if you do it right and your technique is good. And hopefully this document can let you have good technique. But if you don't know what good technique is, then you're in the right place, because that's the whole point of this course.